Hi, everyone. Welcome to our National Infertility Awareness Week webinar. We're bringing a lot of content to you this week and happy that you could join us today. My name is Nina Restkova. I'm a physician with Boston IVF, and I work at the Downtown Boston Center. And happy to answer any questions today. Specifically, I'll be talking with you about LGBTQ plus family building. That's an area of clinical and research interest for me. So I'm going to pull up a couple of slides. I just wanted to give a little bit of an overview about some of the services that we offer. You will have the opportunity to ask questions. It's okay if they also don't pertain specifically to LGBTQ plus family building. Today we have about half an hour, so a little bit of a shorter session today, but happy to discuss, or if you have any questions and follow up to this, we can also try to answer them. Our marketing team is on the line, so they can take some of that information down and try to disseminate some answers afterwards. Okay, so thanks again for joining in. As far as the initial kind of discussion, I think it's always good for you all to know, what does a reproductive health checkup entail? So what happens when you call a fertility clinic for a fertility evaluation to explore your options? Well, you're typically booked for about a 45-minute or 1-hour appointment with a reproductive specialist. It could be one of our nurse practitioners, one of our physician assistants, or one of our physicians. We do have centers all over New England and also in other regions as well. So we'll try to get you plugged in with somebody who's close to you. We have centers for monitoring across our regions as well. That provider will review your medical history and make some plans for fertility testing as well. And there'll be some discussion of potential treatment options and as well associated timelines and costs of treatment as well, should you choose to proceed. We at Boston IVF are a full spectrum fertility care center. So we can help you with a fertility workup, fertility testing. We can also monitor your natural cycle if that's of assistance, particularly for treatments like insemination with donor sperm. We do egg freezing, in vitro fertilization. Also, something that we'll talk about today that people ask a lot of questions about is partner-assisted reproduction, as well as egg donation and surrogacy. So what does a fertility evaluation involve? Well, typically you're going to have an ultrasound starting out. If you're somebody with ovaries and a uterus, you're going to have an ultrasound to evaluate the anatomy. And that ultrasound can be done a couple of different ways. Most often we do an internal ultrasound because the anatomy is pretty small, so it's more easily seen intravaginally. However, if you're not comfortable with that, a transabdominal ultrasound can also be performed to evaluate the ovaries, which are right here. And then the uterus and whether there's any abnormal structures in either of those. Some blood work as well. If you're assigned female at birth, you're going to check the ovarian reserves, the activity of your ovaries through some blood tests, including an anti-Müllerian hormone or AMH. We're also going to do some prenatal labs to make sure that you're healthy for any treatment or pregnancy, do a standard STD panel, and then, of course, genetic testing as well if you're interested in having a genetically linked pregnancy, understanding if there's any genetic risks that may be passed on to your pregnancy, some of which may be able to be prevented through in vitro fertilization. We also test for folks who are interested in donor insemination for CMV, cytomegalovirus, to make sure that we know what kind of donors you're eligible to choose. If you're interested in donor insemination, it's also a good idea to get an HSG, which is a hysterosalpingogram. That's called a dye test. Sometimes you hear about it as a dye test of the uterus and tubes. And it basically involves putting some dye with a catheter through the cervix, which is the opening to the uterus, spilling the dye into the uterus, which then kind of expands the walls here of the uterus. And you'll see kind of looks like an inverted triangle. And then if the fallopian tubes are open, the dye will spill through the tubes as the dye is being passed through. And we take pictures of that with X-ray. So we can understand if your fallopian tubes are normal and if the egg and the sperm are able to meet in the fallopian tubes and travel together as an embryo down to the uterus for implantation. So people who are thinking about doing insemination often ask, why do a checkup before starting treatment? I can do insemination home. Maybe you have a known donor that you want to work with. Well, it's really important to review all the medications that you're taking, manage any underlying health conditions that you may have, and really this sort of broad concept of preconception counseling is really critical in optimizing your health for pregnancy, your chances of success for pregnancy, as well as your health for pregnancy. If you have any underlying gynecologic issues, such as uterine fibroids, irregular cycles, polycystic ovarian syndrome, or endometriosis, those can be addressed there. And certainly, folks with those underlying conditions are going to benefit more from doing treatment at a fertility clinic to optimize your chances of success. So artificial insemination, very, very common starting point if you're working with donor sperm. And this can be done through a couple different ways. The way that it's done at Boston IVF is through an intrauterine insemination, or IUI, but it can also be done at home with an intravaginal or kind of cervical insemination. The difference is that if the sperm is going into the uterus, it has to be washed beforehand and stripped of these proteins, which can be irritating to the uterine lining. And so at a clinic, a fertility clinic, it's going to be a washed sperm sample, and it's going to be entering the reproductive anatomy at a much higher point up in the upper portion of the uterus. So essentially, more sperm are able to get through the uterus and up into the fallopian tubes to meet the egg. There's sort of varying treatment strategies based on your history and your goals for family building. But generally, if you're under 35, it's reasonable to do about 6 rounds of insemination before thinking about more aggressive treatment strategies. Then if you're over 35, less treatment cycles, or potentially even considering more aggressive forms of treatment like IVF sooner. And it's important to know that there's a number of different ways that insemination can be performed. Some cycles can use medication to coordinate the growth of your follicles, and some cycles don't need any medication at all. We can use your natural cycle. So what about the next step? What if you're not successful with insemination? Well, IVF may be a great treatment option, either first line, or if you haven't been successful with inseminations, be they home inseminations or clinic-based inseminations. IVF is highly successful in some of our most successful age groups under 35. The success rate can meet, or even some cases exceed, 50% per treatment cycle. So highly successful, but the success rate is age dependent. In vitro fertilization involves taking shots, so daily injections, and you're taking those in your belly generally. They're pretty well tolerated, not too many reactions, but it is typical to feel bloated because you're going to be making a lot of eggs with the stimulation, and some fatigue is common during IVF treatment as well. You do need to have some blood work and ultrasound done regularly to monitor the progress. And then ultimately you have a surgery to extract the eggs, and that's done under anesthesia, so you're comfortable. We can also, with IVF, test embryos for genetic defects as well as chromosomal abnormalities. And embryos through IVF can be transferred at the same time that they're created. That's called fresh transfer, or they can be frozen and thawed at a later time for transfer. And depending on your particular case, you may benefit more from one versus the other approach. So what about reciprocal IVF? We hear a lot about that. It's of growing interest to our same-sex female population. People who are interested would benefit from it if they're interested in being a genetic parent, but they're not interested in carrying the pregnancy. So essentially, one partner with ovaries undergoes a stimulation for an egg retrieval, and then the second partner with the uterus undergoes preparation of the uterine lining for the embryo transfer. This can all be done real time. It can be coordinated to happen as a result of one treatment cycle, or it can be done over the span of a couple of months once we have some additional information about the embryos that have been created. For example, genetics, or simply the quality and the number of embryos. This provides a tremendous opportunity for involvement of both partners in the process of family building, and the success rates are excellent. We've done a lot of research in reciprocal IVF, really contributed to the literature internationally on this topic, and the success rates are excellent. So definitely, if you're interested in this strategy, talk to one of our team members. We can tell you more. For our transgender patients, for those who are assigned female at birth, there are a number of treatment strategies that are available. For fertility preservation, so preserving your fertility before starting any gender-affirming treatment, you can consider freezing your eggs or even freezing some of the ovarian tissue. We don't offer that as a tissue preservation, but we do actually do a lot of treatment for egg freezing before starting testosterone. Sometimes our trans patients are interested in carrying pregnancy, so donor insemination would be an option, or reciprocal IVF with a partner carrying the pregnancy. Some of the specifics of things that we can do for our trans patients, which can make it a little bit more comfortable to undergo treatment, really working on fostering an open and inclusive environment. We do also work with many of the major insurance and workplace benefits plans, so we can offer you a center, that works with your coverage to optimize and really minimize your out-of-pocket expenses. Some of the things that my transgender patients really appreciate is the possibility of not inducing a menses, not having a period prior to treatment, and that is possible through careful monitoring of your testosterone levels. We can also offer transabdominal ultrasound through the process of fertility treatment and work towards less frequent or more flexible monitoring. And I think a lot of this comes down to having good rapport with your medical provider, just really feeling like we understand the journey that you're on. We did participate in a landmark study on assisted reproductive outcomes for female-to-male transgender patients. So this has gotten a lot of interest and provided a lot of education for our colleagues across the country. We also do a fair amount of surrogacy for male individuals and couples. If you're interested, definitely reach out. We do have a third-party program that can provide you with a lot of information about costs of treatment, timelines for treatment, some of the specifics, the legal specifics as well that are involved. I will share with you that the success rates with surrogacy and egg donation are tremendously high, and that you can work with somebody who is known to you as an egg donor or a surrogate. Although we also work with several donor egg banks. So if you're interested in working with a donor egg bank, we work with several reputable egg banks with high success rates. So definitely happy to talk with you about these options as well, if that's something that applies to you. So that's the kind of overview of my discussion points today. We have a good chunk of time for questions, and I see that a few are coming through the chat and the Q&A. Let's take a look. I've gotten a few questions beforehand as well, and I think we're getting some of the same questions, so I'll just get to those here. Charlie asks, what are the pros and cons of using a known or non-identified sperm donor? Well, there's multiple. In terms of working with a known sperm donor, you have that relationship and that understanding of that person. They may be familiar to you, or they may even be related to somebody that you know, or potentially your partner. So that's definitely important. As far as cost, depending on the type of treatment that you're pursuing, there's sort of a higher upfront cost of working with a directed or known sperm donor, because you have to pay for the quarantine of the sperm, some testing, some evaluation of that person, but you may have many vials of sperm that are ultimately frozen. So on a per vial basis, the cost may be decreased. Whereas working with a non-identified sperm donor, somebody that you don't know, that you're getting sperm from a sperm bank, you don't have that relationship, but the cost per vial, the upfront cost may be a little bit less. We do recommend that donors are carefully screened and have broad genetic testing, and the sperm banks, generally speaking, are doing very broad genetic panels, so it's quite safe. And those donors have, very well-established sperm parameters, so the sperm quality is going to be consistent from sample to sample. It's pretty hard to become a sperm donor for a sperm bank. There's a lot of people that are ruled out, so the quality of the sample is going to be really consistent. Okay, great question. Next question is, how many IUIs do people typically do before moving on to IVF? So I touched on that a little bit in our intro. It depends on your age. If you're under 35, it is very reasonable to do up to 6 rounds. Our internal data does suggest that the best success rates are really over the first 3 or 4 IUIs, and that's coming out to be pretty consistent with published data as well. So you're going to get the most success rates for 3 or 4, but it's reasonable to complete up to 6 if you're kind of nervous about IVF, or you have an insurance requirement to complete the 6 IUIs. But there are different approaches that you can try. So if you're not having luck with the first method, there are ways you can change it up to kind of optimize your chances of success. So definitely talk with your medical team about that. And then somebody asks, could I outline how egg freezing would work as a transgender patient? Absolutely. So it depends if you've been on testosterone treatment or have not been on any testosterone treatment. The timeline could differ just slightly. Good news is we can definitely check your egg reserves, the quantity of eggs that you have even while you're on T. And that can be done through ultrasound, which can be, as I mentioned, vaginal or transabdominal. If you're on testosterone, it's much more comfortable to have a transabdominal ultrasound, actually. And then we can check your blood hormone levels to check your ovarian reserve. That's really not impacted tremendously by the testosterone. And then make a plan for treatment. I recommend for my patients to do careful monitoring of testosterone levels. Get off your testosterone for a short stretch, and once your hormone levels have dropped closer to the upper limits of the female range, then we can go ahead and start treatment. It's technically possible to do stimulation while you're on testosterone as well. There's been case reports of that more and more across the country. We don't yet know whether the outcome, so the number of eggs that you get or the quality of the eggs, is impacted. There's not enough literature to let us know definitively if it impacts the quality or quantity, but certainly something that could be considered as well. As far as this ovarian stimulation, it's just like egg freezing for any other individual or IVF treatment. You're on injections for about 8 to 12 days. You're coming in for blood work and ultrasound every 2 or 3 days, and then you're having a surgery to extract the eggs. Okay. Great question. Next question is, what is the timeline for IVF for a same-sex female couple? So the timeline is, first you need to get a consult. I'd say in general, you could get in to see a fertility specialist or start the process of testing within 1 to 2 months. So if you give us a call, I think that would be a very reasonable timeline. If you're regularly menstruating, then we would recommend that you do your testing with your menstrual cycle. That gives us the most information. It's the most clear. It gives us the most insight into your ovarian activity. And that testing generally takes about a month. So we would basically reconvene after the testing is complete, and then make a plan for treatment. If you're looking at IVF, and you're looking at sort of autologous IVF, so extracting your own eggs and then carrying an embryo derived from your own eggs, oftentimes that can be done in 1 treatment cycle. And a treatment cycle is generally 28 days, just like a menstrual cycle. So you're taking injections for 10 to 12 of those days and having a surgery to extract the eggs, and then having an embryo transfer 5 days later. And then at the end of that 28-day time frame, you're having a pregnancy test to understand if the pregnancy test is positive, you've been successful. If you're considering doing reciprocal IVF, where one partner's carrying an embryo derived from the other partner's eggs, then in that case, most often kind of a 2 to 3 month process, because we would meet back to review how those embryos have fared, how many embryos there are, and the quality of them, and then make a plan for transfer for the other partner. Okay. And we actually have a reciprocal IVF question as the next one. My partner and I are considering reciprocal IVF, and both of us are interested in carrying eventually. How do you decide who should carry first? That's a very nuanced question. It's so different for each partnership, for each couple that I've worked with. In many cases, we'll consider kind of health factors, age, and then in some cases, we'll also consider ovarian reserve, the activity of your ovaries, as a factor as well, particularly if one person is intending to delay treatment. So it's pretty nuanced. We consider this. We spend a lot of time kind of thinking about pros and cons. I find that most patients kind of have a pretty clear feeling of how they'd like to proceed. But if there's some neutrality, then we'll kind of talk through the options, and I can make a recommendation for you based on the underlying sort of health history. But usually age, the healthiest pregnancy is going to be under age 40. So really we want to optimize both of your pregnancy journeys to at least start and maybe even conclude by that time. So we'll definitely factor that in based on how many kids you're interested in having, how large a family you want to have, and who wants to carry. The next question is IVF expensive, and are there any funding option? IVF is expensive, yeah, but there are a lot of new workplace benefits and insurances that are covering IVF treatment sooner, even for LGBTQ couples. So I would definitely encourage you to look into your workplace benefits to see if there's anything that is offered through your workplace. If there isn't, talk to your HR team, advocate for yourself, for your friends and your colleagues. If this is something that would, help you. Oftentimes people just don't, they just don't know. So if you can educate them, I've seen, change happen on a kind of a grassroots level that way. So I would encourage you to do that. If you are needing to do self-pay IVF treatment, we do have payment plans that are available for that. And then we also have a Boston IVF Foundation, which has some grant support for our patients as well that you're welcome to apply for. Typically, your physician can help you with that as well and advocate for you. So definitely something to look at. There's also some other grants available online, different programs have that. So if you do some research or join some kind of online support groups, you may be able to get more information through that. Hi, Anonymous. Thanks for the shout out. And then we have one more question. How many vials of donor sperm do you recommend purchasing for IUI? Roughly, I would recommend starting with 2 to 4 vials per intended pregnancy if you're starting with insemination. Most people who are pregnant with insemination will be pregnant within 2 to 4 IUIs. Occasionally, we get somebody who gets really lucky and gets pregnant with the first try and then has a lot of surplus sperm. But on average, you can expect 2 to 4. And so, the goal is if you want to have more kids down the line and you want them to be genetically related, you want them to have the same sperm source, then you want to have some surplus sperm available on hand to help you achieve that goal. We can, kind of as a last resort, if there's no more sperm available and you really want a genetically related sibling, then we can use sperm in very sort of limited amounts, and we can use that for IVF, in vitro fertilization. But IVF, obviously, a lot more technology, a lot more medications, a lot more expensive. So the goal for you is going to be to have enough sperm purchased so you have still a good chance of success with insemination in the future. And then kind of, have IVF as a backup option if we're getting to the last little bit of sperm, we can conserve sperm with IVF treatment. All right, so I think we have done a good job with the Q&As here. So I had a couple of Q&A questions beforehand, so we can get to those and wrap up probably by about 1 o'clock to get you back to work after your lunch break. Okay, so a patient is asking, I know I need to choose between donor eggs or donor embryos. Does one option have a higher success rate? It depends. So if you're using donor eggs, there's a couple of different ways to get donor eggs. You can get donor eggs from a donor egg bank, in which case you're typically purchasing somewhere between 5 to 8 eggs at one time. And the likelihood is that you'll get 1 or 2 good quality embryos as a result of those eggs. Each of those embryos would have about a 40% success rate. Donor embryos, it really depends on what program the embryos have been created at, if they've had genetic testing of those embryos, and if there's been prior success from families or individuals who've used those embryos. So I would say that the age of the egg source is really important, and then whether genetic testing was done. If they are embryos that were created at a reputable IVF center with a strong laboratory and the genetic testing has been done on those embryos, they could be as high as 50 or 60% chance of success per embryo, if that person was successful previously. So I would say do your research, and I would probably very carefully evaluate both options, and talking to a fertility specialist at Boston IVF would be very helpful for that. They could talk you through the individual steps, individual circumstances. Somebody's asking about donor sperm. And the question is, how many vials of donor sperm do you recommend purchasing, which we kind of just talked through? And then is 1 whole vial equal to 1 try? So for insemination, yes, you would need to use a whole vial. The vials are designed to give you a good chance of success if they're used in their entirety. So all the vial needs to be used. And then for IVF, we can use just a portion of a vial. So it is possible to do that, but usually we have to use an advanced insemination strategy like ICSI, which is a little bit more expensive. So for IVF, we can conserve sperm and use just a portion of a vial, a fraction of a vial, but for IUI, we do need to use a whole vial. All right, and I think we have one more question. How often does IUI work on the 5th or 6th round and don't have to go to IVF? The starting rates, success rates of IUI are, on the sort of our best prognosis patients, are about 15 to 20% per cycle. And then the success rates drop off, definitely less than 10%, in some cases less than 5% per cycle on the 5th or 6th round. I will say I've definitely had patients, maybe they're even on this call, who've had success on cycle number 5 or cycle number 6, completing an insurance requirement, but it's more rare. It's more rare. So under 10% for around 5th and 6th, still worth completing, if that's your preferred approach. But the success rates of IVF start to be much, much higher than IUI at that time. As I shared with you, success rates in our best prognosis group can easily exceed 40 or 50% per treatment cycle. So IVF becomes more compelling at that point, particularly when you think about, using one vial of sperm and kind of distributing that sperm across all the eggs from an IVF cycle versus kind of the one egg of the month that you get with the IUI. All right, everyone. Well, it's been a pleasure to spend part of the lunch break with you all today. Thanks for listening in, and thanks for all the great questions. And just wishing you a great rest of your day. I do want to put a plug in for my colleague, Dr. Sarah Arian, who's speaking with a fertility Q&A this evening, I believe, at 7 o'clock. So tune in for that. Lots of great information. I'm sure we'll be there as well. All right. See you next time. Bye, everyone.